Namaste, this is Dr. Norris Gurung, Registrar of Pulmonary, Critical Care and Sleep Medicine Department of Nepal Medcity Hospital, Vaisipati, Lalitpur, Nepal. In this video, I will be talking about the role of Remdesivir in COVID-19. Remdesivir is the first drug which has been approved by the US Food and Drug Administration for treating SARS coronavirus 2, issuing an emergency use authorization on May 1 of 2020. In the context of Nepal, it was given the permission to use as a study drug on August 9 of 2020. In my upcoming slides, I will be discussing about these questions that comprise if the use of Remdesivir improve patient outcomes like mortality, need for mechanical ventilation, requirement for organ support, intensive care unit length of stay, and hospital length of stay for patients who have been hospitalized with COVID-19, and also which patients hospitalized with COVID-19 will receive the most benefit from Remdesivir, and recommended duration of therapy for Remdesivir. How is Remdesivir being used to fight COVID-19? FDA had to issue an emergency use authorization to give for its use. In August, the FDA expanded its emergency use authorization, allowing all the hospitalized patients with COVID-19 to receive the drug, including people with mild and moderate disease. How does Remdesivir help patients with COVID-19? It directly inhibits viral RNA synthesis of SARS coronavirus. It also prevents the virus from producing a particular enzyme which is necessary for virus replication and stops the virus to spread within the body, and also reduce the mortality and progression to mechanical ventilation in moderately ill patients who have been hospitalized with COVID-19 on supplemental low-flow oxygen. So, summary of recommendations for Remdesivir by severity of COVID-19 illness. Patients who are critically ill and under invasive mechanical ventilation or ECMO, Remdesivir is not recommended. Patients who are critically ill requiring high flow oxygen or non-invasive mechanical ventilation, Remdesivir is recommended. Moderately ill patients with low flow oxygen, Remdesivir is recommended. And patients with mild disease, Remdesivir is not recommended. So different randomized control trials from around the world have compared Remdesivir effect to placebo or to routine care alone on hospital patients with COVID-19 were reviewed. Even though the results of trials varied, most of the trials showed that Remdesivir might decrease deaths and the need for mechanical ventilation, and it also speeds up the recovery as well. One of the clinical study which is done by National Institute of Health indicated that patients receiving Remdesivir had a median recovery time of 11 days as compared with 1 to 5 days in those who received placebo. Although mortality was also lower in the Remdesivir group, it was not statistically significant. 4 randomized control trials have been released as of April 14 of 2021, studying the effect of Remdesivir on a total of 7,334 patients hospitalized with COVID-19. Among 4 randomized control trials, 2 were placebo-controlled and 2 randomized patients to Remdesivir on usual care. One of these trials compared Remdesivir 5 days versus Remdesivir 10 days, but also compared each against placebo. A 5th trial compared Remdesivir 5 days versus 10 days in patients hospitalized with COVID-19 requiring supplemental oxygen. Here I have mentioned one of the clinical trials as a representation which studied effect of Remdesivir versus standard care on clinical status at 11 days in patients with moderate COVID-19. This study concluded that more number of deaths, need of invasive mechanical ventilation, ECMO, non-invasive ventilation or high flow oxygen among patients under standard care, whereas less number of deaths, need of invasive mechanical ventilation or ECMO, non-invasive ventilation or high flow oxygen among patients under 5 and 10 days Remdesivir use. So this is a bar chart which shows the day 11 clinical status of hospitalized patients after the use of remdesivir. Patients under standard care are more prone to increase in death number and also hospitalization requiring supplemental oxygen and non-invasive or invasive ventilation than the patients under the 5 and 10 days remdesivir use. Adaptive COVID-19 treatment trial. So the initial emergency use authorization for remdesivir was based on preliminary data analysis of the adaptive COVID-19 treatment trial. It was announced on April 29 of 2020. This analysis included a total of 1,062 hospitalized COVID patients, which showed that patients treated with 10 days of remdesivir had a 31% faster time to recovery than those who received placebo. A statistically significant difference was not reached for mortality by day 15 or by day 29. Rather than mortality, the primary endpoint for the adaptive COVID-19 treatment trial was time to clinical recovery, which is defined as either discharge from hospital or continued hospitalization without the need for supplemental oxygen or ongoing medical care. Similarly, another clinical trial regarding the role of remdesivir in COVID-19 is Solidarity trial. So, Solidarity trial concluded the decrease in mortality with remdesivir among patients requiring low flow or high flow oxygen, but not among those requiring mechanical ventilation at baseline. Adaptive COVID-19 treatment trial solely focused on the effect of remdesivir on changing the course of hospitalization, whereas the larger, simple, randomized Solidarity trial focused on more easily defined outcomes. So this table summarizes the result of meta-analysis of 4 different randomized control trials. So the first table, it summarizes the meta-analysis of all the released randomized control trials in hospitalized patients with COVID-19, irrespective of their severity of illness, comparing remdesivir with placebo or usual care on all-cause mortality at 14 to 20 days from initiation of therapy. Results are inconclusive with a pooled relative risk of 0.93. So this second table, it summarizes the meta-analysis of the composite of mechanical ventilation or death. Based on all the available data, remdesivir reduced the risk of mechanical ventilation or death at 28 days. So the other outcomes regarding the use of remdesivir are the need for organ support, hospital length of stay, and recovery. So in all these randomized control trials, which was where it was studied that remdesivir reduced the need for ventilation or ECMO at follow-up with a pooled relative risk of 0.71. In adaptive COVID-19 treatment trial 1, the median time to recovery was 2 days shorter for those on supplemental oxygen via nasal prongs at baseline given remdesivir compared with placebo. In the two smaller randomized control trials by Wang et al. And Spinner et al., remdesivir shortened the time to clinical improvement with a pooled hazard ratio of 1.17. Remdesivir versus placebo may reduce hospital length of stay with a mean reduction of 5 days because the Solidarity trial requires patients to remain in hospital to complete all the full treatment course. The study design biased the trial towards no effect on hospital length of stay. Remdesivir resulted in a higher proportion of patients recovered compared to control with relative risk of 1.09. So, in conclusion, based on all these studies and combined clinical experiences, international guidelines recommend the use of remdesivir in the treatment of COVID-19. The US National Institute of Health panel also recommends using remdesivir for 5 days or until hospital discharge, whichever comes first. Among the hospitalized patients with severe COVID-19, the Infectious Disease Society of America panel also suggests remdesivir therapy over no antiviral treatment. Remdesivir is hence recommended in moderately ill hospitalized patients with COVID-19 requiring supplemental oxygen. The benefits of remdesivir for critically ill patients requiring supplemental oxygen via high-flow nasal cannula or mask or non-invasive mechanical ventilation is uncertain. Remdesivir does not benefit and may harm critically ill patients already receiving mechanical ventilation or requiring extracorporeal membrane oxygenation (ECMO) and it does not provide substantial benefit for hospitalized patients who do not require supplemental oxygen. Thank you.